respected dignitaries, esteemed faculty members, distinguished guests, dear colleagues, a very warm good afternoon to one and all. It gives me great pleasure to welcome you to this meaningful celebration of International Women's Day 2026. Now I request our Registrar Sir, Dean Sir, Dr. Lopa Ma'am, and Dr. Vandana kindly occupy the dais. Please sir, please ma'am. Before we begin the program, may I kindly request everyone to rise for the SBV anthem.
Education gives humility. Humility gives character. From character, one gets wealth. From wealth, one gets righteousness. In righteousness, there is joy.
Thank you. Kindly be seated. I, Dr. Rajeshwari S., Member Secretary of the Women's Cell SBV, it's my honor and privilege to host this wonderful event. Every year on March 8th, the world celebrates International Women's Day, a day that recognizes the achievements, strength, and resilience of women across all fields. The theme for this year, Empower, Inspire, Lead. Empower, because when women are empowered, communities flourish. Inspire, because women continue to inspire change and progress. Lead, because women are leaders in science, healthcare, education, and society. Today, we celebrate brilliance, we celebrate resilience, and most importantly, we celebrate women for their achievement with all great men around them. Therefore, today's program highlights not only celebration but also awareness about women's health and preventive care. When women rise, societies rise with them, and healthcare plays a vital role in that journey. To formally welcome the gathering, I invite Professor Lopamutra Patacharya, Head of the Department OBG MGM CRA, to deliver the welcome address. Ma'am, may I request you to kindly address the gathering.
Good afternoon. On behalf of Sri Balaji Vidyapith Women's Cell and the Department of Obstetrics and Gynecology, Mahatma Gandhi Medical College and Research Institute, I extend a warm welcome to one and all present here. Today we have gathered together to celebrate the International Women's Day, and we are extremely delighted to have our guest speaker of the day, Dr. Unnop Jaisamrarn from Chulalongkorn University, Thailand, who will be delivering a short lecture on bone health across menopausal transition. I hope all of us enjoy the program a lot and get to know a lot of important things from Sir's lecture. Thank you so much.
Thank you, ma'am, for those warm and inspiring words of welcome. Music is the language of the soul, and a beautiful beginning deserves a beautiful melody. We now present Swagatam Ragamalika, a musical welcome through a garland of Indian classical ragas, symbolizing respect, harmony, and celebration. May I invite Professor Srinivasan, Registrar SBV, to grace us with this beautiful musical offering and warmly welcome Professor Unnop Jaisamrarn to SBV.
தன்னிறைவ இதயம் உன்னப் ஜெய்சம்ரன் ஞானம் தூய தன்னிறைவ இதயம் கொள் உன்னப் ஜெய்சம்ரன் உமை நாம் தன் தமிழாக மாலை தன் தமிழ் ராகமாலை அதனால் தன் தமிழ் ராகமாலை அதனால் வணங்குவோம் நீர் வருக வருக உன்னோப் ஜெய்சம்ரன் உமை தன் தமிழ் ராகமாலை அதனால் வணங்குவோம் நீர் வருக வருக ஸ்ரீ பாலாஜி வித்யாபீட்டம் மனம் குளிர்ந்திட வருக வருக உன்னோப் ஜெய்சம்ரன் நீர் வருக வருக மகப்பேறு மகளிர் மருத்துவ துறைதனை ஜகம் போற்றிடுமே திண்ணமே மகப்பேறு மகளிர் மருத்துவ துறைதனை ஜகம் போற்றிடுமே திண்ணமே உன்னப் ஜெய்சம்ரன் உந்தன் ஆக்கம் தனை மகப்பேறு மகளிர் மருத்துவ துறை அதற்கு நீர் தரும் ஆக்கம் தனை உணர்வோமே உன்னப் ஜெய்சம்ரன் அவர்களே ஸ்ரீ பாலாஜி வித்யாபீட்டம் மனம் குளிர்ந்திட வருக 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 உன்னப் ஜெய்சம்ரன் வருக வருக வருக.
Thank you, sir, for the wonderful musical presentation, which truly set a graceful tone for today's celebration. The musical garland is composed of 3 classical music-based ragas, namely Mohanam, which is a pentatonic musical scale that is the same as the mode used in Thai music. In addition, the musical garland contains 2 more Indian classical ragas, namely Kiravani and Sindhu Bhairavi. Unnop Jaisamrarn in Thai language denotes a person whose wisdom is as vast and deep as an ocean and one who has a pure and contented heart. The song also hails the role of contributions to obstetrics and gynecology by Professor Unnop Jaisamrarn. We welcome him to the SBV fraternity. Our today's speaker is from the country known as Land of Smiles, a vibrant and culturally rich place. I am confident that the deliberation by today's speaker will be as delightful as the food and hospitality of his land. May I request our Dean Sir, Professor Sitesh Ghosh, to introduce our today's speaker to this august gathering and kindly take over to moderate the session, sir. Please, sir.
dignitaries on the dais, SBV faculty from all the constituent colleges, and my dear students. It is my honor to introduce Professor Unnop Jaisamrarn, MDOG, MHS. Besides being an obstetrician and gynecologist, Professor Jaisamrarn is a distinguished expert in the field of women's health, currently serving as the director of the Global Women's Health Program, Senior Executive Advisor for International Affairs, and Chairman of Institutional Review Board at the Faculty of Medicine in Chulalongkorn University in Bangkok. With a wealth of experience and expertise, Professor Jaisamrarn is also President of the Reproductive Health Association of Thailand and has held leadership positions in organizations such as Thai Osteoporosis Foundation and Thai Menopause Society. Internationally, he plays a crucial role as the President of the Asia Pacific Menopause Federation, Honorary Secretary of the Asian Federation of Osteoporosis Society, Chair of Asia and Oceania Federation of Obstetrics and Gynecology, Sexual and Reproductive Health Committee, member of the Committee on Contraception of the International Federation of the Gynecology and Obstetrics, and is a member of WHO Advisory Panel. With over 30 years of collaboration with the WHO, Professor Jaisamrarn's contribution to research and training in reproductive health, menopause, and osteoporosis are truly commendable. He was trained in Johns Hopkins University and University of Hawaii and has numerous international publications. Please join me in welcoming Professor Unnop Jaisamrarn to this session. Thank you.
Thank you, the Dean of the SBV University for inviting me to give a talk today and for introducing me. Shall I start my presentation now, or is there any other things we need to do?
No, sir. Please, sir. Please proceed, sir.
Okay, so let me share my slide. And thank you very much for the audience, who come, for the International Women's Day special talk today. I'm an obstetric and gynecology, and I work for aging women in the field of menopause and osteoporosis. So what I'm going to share with you today will be related to bone health across the menopause transition. And so let me share my screen. My talk won't be long. It would take like around 20-25 minutes. And if we may have time, we can have a time for a question or discussion at the end of my presentation. So start with the conflict of interest. I have nothing to disclose. I have done a lot of research and academic activities with some of the pharmaceutical companies as shown in this slide. But no product is related to what I'm going to speak today. So we all know that when women enter menopause, a lot of changes, will follow. So what is the time, the age of menopause in India? I think it should be the same as what we have here in Thailand. Actually, in Thailand, the age of entering menopause in women is around 50 years old. I think in India it should be the same, maybe a little more or less, depending on the genetic factor. And we all know that this is a midlife, and a lot of changes will occur, after the final menstrual period. We all know that estrogen, which is the female sex hormone, produced from the ovaries of the reproductive age women, is essential for everything, I would say, all organs, all tissues in the women body from head to toe. When women enter menopause, 50 years of age, the ovaries stop producing estrogen, stop producing female sex hormone. What happened? A lot of change, in terms of degeneration occur throughout the body from head to toe as well. A short-term functional change may occur in a proportion of women, like autonomic nervous system. The gynecologists know well. The hot flash, the insomnia, inability to sleep, the mood swing, mood change, inability to concentrate, and a lot of change, will occur, before and after the final menstrual period. This is a functional change from the abnormal in terms of the function of the autonomic nervous system. Later on, women will experience some of the atrophy of skin, the dryness of skin, and wrinkle. I think, all women don't want to be, to have wrinkle on your face or maybe on your body, but it's gonna happen after estrogen deficiency. And the urogenital symptom is mean like the vaginal dryness and pain, at the vagina, and some problems with the urinary system like the stress, incontinence, and so on, can occur 2 or 3 days after the final period. And 5 to 10 years after the final period, we can detect a change in the cardiovascular system and the bone system as well. We all know that osteopenia with its low bone mass and osteoporosis, will occur after, depletion of the estrogen in menopause. We have been taught that the estrogen deficiency will lead to bone loss after menopause, like 5, 10 years, or even 20 years after menopause. We may not, consider, this important during the menopause transition or at the time when women enter menopause. But what I want to propose today is that osteoporosis in menopause, although it will end up with the fracture or osteoporotic fracture, it occurs very early before the final menstrual period and right after the final period. I will show you next. But importantly, let me share with you the projection of hip fracture in Asia. I have worked with the team of the Asian Federation Osteoporosis Societies in like around 10 regions and countries to do this paper. You can see here, this is the incidence of hip fracture in women and men in Asia. You can see that, almost, all region and country, including India as well. When women getting older, the left-hand side is for women, and on the right-hand side is for men. You can see that after entering menopause, particularly 10 years or 20 years after the final period, you can see a sharp rise in the incidence of hip fracture. It is important. We all know that hip fracture will end in fatality and in mortality in most cases. So we don't want to wait until all of our women will enter the late postmenopause and having the fragility fracture and hip fracture. And most of the hip fracture in the next decade will occur mostly in Asia because of the aging population. We need to be well aware of this before these things happen. Let me share with you our own study in Thai women. It will be the same as in Indian population as well. This is the bone density or the bone mass measurement of the lumbar spine in women of different age group. you can see women after entering puberty, like 10 or entering adolescence, the bone density will be increasing, and the peak bone mass, it means the strongest bone uh, can be seen at around 30 to 35 years old, and after that a little decline, even before menopause. uh, uh, we found that, uh, a small and slow decline in the bone density. But after 50 years old, you can see here, after 50 years old, the bone density will decline very fast. This is what happened, in cases of menopausal women. And this is the terminology table. I don't want to go into detail, but the most important period is, 1 or 2 years before the final menstrual period, let's say like 50 years old, that will be around 48 to 49 years old, before 50 years old, which will be the final period, and 1 or 2 years after the final period. This period of the transmenopause or menopausal transition is very important. A lot of changes, can occur because of the depletion of estrogen, in this period. But what I want to emphasize today is that the bone density, although, you can see the outcome of the bone, low bone mass or osteoporosis later in life, like 10 or 20 years after the final menstrual period. But all these change of the bone health occur during the menopause transition. Let's take a look at this. You can see 0 is mean the final menstrual period. 1 year before the final period, you can see that the bone density, either at the lumbar spine and the femoral neck, start to decline even before the final period. And the decline, continue and very fast during the first 2-3 years after the period. We call this the menopause transition or transmenopause. And this slide shows you the prevalence of osteopenia, which is the low bone mass, and osteoporosis in postmenopausal women by ethnicity. You can see, all ethnic groups, including the Asian women, follow the same proportion. So around 1/3 of women, in menopause, we have osteopenia. This is some of the WHO definition. If you measure the bone density and the T-score fall between -1 to -2.5 standard deviation, we call this osteopenia. And if the bone density fall below -2.5, we call osteoporosis. And you see that around 20% of postmenopausal women, we have osteoporosis, and 1/3 we have osteopenia. And all these, follow the same proportion or pattern, amongst different ethnicity. And I think in India, it should be the same, more or less. This slide shows very important message about the menopause transition. This comes from a swan study in the US. You can see the final period here is 0. You can see before 1 or 2 years before the final menstrual period, estrogen level start to decline and follicle stimulating hormones start to rise. This is the signal. This is the signal that women will enter menopause very soon. And during this period, if you measure the bone, that we call the bone turnover marker, and show the high bone resorption, you can see that the bone markers start to rise 1 or 2 years before the final period, and the bone density start to decline 1 year before the final period. It means even before the last menstrual period, all the change, related to bone loss already started. And 1 or 2 years, or maybe no later than like 3 years after the final period, all these changes, continue, particularly bone density, decline, rapidly after the final period. So what I want to emphasize for my talk is that although the outcome of the bone loss in menopause can occur very late in life, like fracture at 60 years old or 70 years old, but all these changes start very early. After and even before the menopause or final period. So we need to, be aware that at this point of time of the menopause transition, it is the window of opportunity for us to detect very early in terms of the bone loss. And if we can provide the woman with some early intervention, this can help the rapid change, in bone density. So take a look again of the pattern of bone loss after menopause. As I already shared with you, the peak bone mass is around like 30 to 35 years old. And after that, women will have the bone loss very slow, less than 1% a year until 50 years old, final period. After the final period of 50 years old, women will have a very fast bone loss, even like 5% a year for 5 to 10 years. And after that, the bone loss will occur, slower, like 1% a year. This is the pattern. So why do we need to wait until like 70 years old or 75 years old when the majority of the bone already gone? Why don't we start doing something during the time of the bone loss? Start here. So this is my question. Which one is more important between bone loss or lost bone? When should we treat? We wait until like 70 years old, like a river of no return. Bone already disappear, the bone strength already disappear, or we should do some early detection and early intervention during the early phase of bone loss. So we think about that. Which one is more important? When should we start the treatment or start the detection? And we all know that although women has osteopenia or low bone mass not entering osteoporosis yet, a lot of women will have fracture. In this, group, particularly vertebral fracture. This is a study in Thailand in my university. We found that vertebral fracture, VF vertebral fracture or spine fracture, were present in around 29% of women with osteopenia. Although women will not enter osteoporosis, they still can have the vertebral fracture around 1/3 or 29%. If we can prevent the first fracture, which is the wrist fracture, and the second fracture, which is the vertebral fracture, we can reduce the risk of having the severe hip fracture. So start early. This is important. This is the message. We have some clinical assessment tools for osteoporosis. We also have some predictors of rapid bone loss during menopause transition, because some women will have a rapid bone loss, some women will have a bone loss but not very fast as other women, depending on the clinical risk factor. We also have the flags, which is the tools for calculating the risk of the fracture. We also have the bone density measurement. We also have some of the laboratory assessment, the sex hormone and bone turnover or bone resorption markers, to predict the outcome. This slide shows you the risk factors of osteoporosis in postmenopausal Asian women. We have a gathering of experts in bone health across Asian region, and we have like a consensus show in this slide. The history of fracture. The history of fracture in first degree relative, it means family history. The advanced age and the female sex and genetic factors. All these, are non-modifiable, risk factors. So if you are a woman, unfortunately, you have higher risk of having a fracture than men. And if you have a history, particularly family history of hip fracture, you have higher risk of having the fracture than other people who haven't had any genetic or family history. And let me show you next. This is the modifiable or potentially modifiable risk factors of osteoporosis in postmenopausal Asian women. Cigarette smoking. So when you stop smoking, you can, get rid of this risk factor. Low body weight. Oh, unfortunately, although low body weight women may seem to be like more attractive than heavyweight women, but low body weight women or thin women, we have lower bone density than big body, women. Estrogen deficiency, early menopause, or long-term use of some medicine, or lifelong low calcium intake, alcoholism, inadequate physical activities, all these are risk factors for osteoporosis. So if you or your relatives, have these, risk factors, they have higher risk of having a fracture. And let me show you, this is the fracture risk assessment tool of FRAX proposed by WHO. You can use free of charge from the website of the WHO, supported by the Sheffield University. And when you enter the questionnaire in these two, you click, and then the system will show you how high the probability of fracture, will be in the next 10 years. This is one way to predict the risk of fracture. And we also have the bone density machine to measure in different parts, like the peripheral machine or the central bone density machine or DEXA, dual photon absorptiometry. The standard will be using the DEXA machine to measure the bone density of vertebra and the hip. And we can know, how high or how low the level of the bone density, will be in the woman. We also can measure the sex hormone. The lower the estrogen level, the higher the risk of rapid bone loss. We can also measure the level of follicle stimulating hormones. The higher the level of FSH will be the higher the risk of lumbar spine loss. And even bone resorption marker, as I shared with you during the early of my presentation, the bone resorption marker will rise before the bone density decline. And the level of bone resorption marker is associated with the amount of bone loss. All these can help, to predict the rapid bone loss during the menopause transition. The early detection can lead to the early prevention and the early treatment. And we have many strategies. We have non-pharmacology, which is very important. All women in perimenopause, transmenopause, or menopause transition should take enough calcium and vitamin D. Calcium 1,000 milligrams a day and vitamin D around 1,000 international units a day, and physical exercise, particularly the weight-bearing exercise. All these are essential, and all women entering menopause should do this. And the right column on the right hand side show you the medicine that we can use for helping to slow the bone loss or even increase the bone density. I won't go into detail, but since we have a lot of things here, the hormone therapy, We have the selective estrogen receptor modulators, we have bisphosphonate, and some other bone forming agent. I won't go into detail of this, but it means that at the moment we have tools to detect a very early bone loss, and we also have the method or the strategy to handle all these changes. This is my own slide. I make this slide by myself. I would propose what we can do, the treatment or the intervention options for the osteoporosis and low bone mass in menopause women. You can see here, healthy lifestyle is the most important. Lifestyle modification, lifestyle medicine is essential. Enough calcium, enough vitamin D, and exercise, including, having healthy food, nutrition, and avoid the risk factors. Some women may have a problem with the genital symptoms like genital atrophy. Local treatment with some of the local hormone may be important and may be needed. Some women, before the final period and during the first 2-3 years after the final period, women may experience the vasomotor symptoms and the sleep problem, and gynecologists may consider prescribing some hormone therapy, lower dose natural hormone to help alleviating the symptoms and can help to preserve the bone density as well. Some women may need some other agent like selective estrogen receptor modulators, which can preserve the bone health and also can reduce the risk of breast cancer as well. Some women may need bisphosphonate, to help, stronger bone, particularly at the hip, bone of the hip, and prevent the hip fracture. And in some very old age, women may need some of the bone forming, agent like the parathyroid hormone or romosozumab. I won't go into detail, but just want to tell you that at the moment, we have ways for early detection, and we also have ways for prevention, intervention of bone loss in menopause women. Let's take a look at this slide. The red line represents the natural way, the natural, I would say, the natural history of the bone density in menopause women. You can see 1 year before final period, bone loss start to decline and very fast during the first 2-3 years. And if we do nothing, it will be like this. Women will lose like more than 10% of the bone density during the first 3 years after menopause and slower after that. But if we can detect very early, we can provide the early intervention. It doesn't mean that giving medicine. It means like healthy lifestyle, calcium, vitamin D, and exercise. We can protect, the bone, and we can help the bone density, to decline in a slower pace than waiting naturally. And this is very important message that I want to convey to you today. Menopause transition is a period of rapid bone loss with lifelong consequences. It means the early change and leads to consequences later in life. And the hormone shift and bone turnover marker can help to identify the risk. And early lifestyle intervention, just want to emphasize early, lifestyle intervention is crucial and timing matters. We need to start very early. And this is a stage for therapeutic option in later life. Thank you for your attention. And I am the president at the moment of the Asia Pacific Menopause Federation. And I'm pleased to invite, you all to attend the 11th APMF or Asia Pacific Menopause Federation scientific meeting, which will be held in Bangkok Thailand in July next year. Welcome everyone. Thank you for your attention.
Thank you, sir, for the highly insightful and enlightening lecture. Knowledge shared is knowledge multiplied. And today we are privileged to learn from an expert in women's health. Dear participants, you are welcome to ask questions and interact. Any questions, please?
Respected Professor, your talk was absolutely fabulous, simple, but yet lot of insight. Am I audible, sir? A lot of insight into the women's health, bone health across the transition period of menopause. And I really like the way you emphasized on the lifestyle changes, exercise, vitamin D, calcium, good health, good food, and less emphasis on the HRT, on the hormone replacement. I would like to know, do you use alkaline phosphatase as a marker of the bone turnover also? Alkaline phosphatase.
So actually, I mean, we seldom, I mean, use alkaline phosphatases as a prediction of bone loss. I mean, most of the tests we use is the beta cross lab.
Okay.
So actually, it depends on the facility in your setting. If you have some other that can measure the rate of bone turnover, that will be fine.
What's your comment on the HRT, low dose HRT you alluded to?
Yes, hormone therapy. I mean, the old term is HRT or hormone replacement therapy, but the new term actually we use the MHT or menopausal hormone therapy. It means that you use the hormone in women with indication. For example, like in women, in women with the vasomotor symptoms is good. I mean, to start using the low dose hormone treatment. And you also have the benefit of the bone loss prevention as well. So it's mean many years ago, like 20, 30 years ago, when women start entering menopause, most of the gynecologists may consider prescribing HRT at that time to prevent aging. But the concept at the moment, so we won't prescribe HRT for all menopause women just to prevent aging. We will use when indicated. For example, the menopausal symptoms or even bone loss. Bone loss is also one indication for hormone therapy as well. And we suggest to use the natural one and the lowest effective dose. And duration can be as long as needed.
Thank you, sir. Thank you.
Good afternoon, Dr. Anup. I'm Dr. Ghosh. I think we met during your last visit to SBV. I don't know whether you remember during IHRC. I just have one questions to you. Like you showed in your first slide that quite high proportion of South Asian populations are prone for, especially female, are prone for hip fracture, right? Yeah. Is it because only the increased aging population or due to some genetic variations?
So basically, the increasing proportion of women with hip fracture is from aging. It's from aging because we have more and more, aging people in our region. And actually, sooner or later, women or even men will have bone loss. So if we do nothing, the proportion of the fracture, will be increasing. And the I would say proportion of women or even men with hip fracture follow the same pattern. It means the older the women or men is the higher the rate of fracture.
Thank you. Thank you. And just to take from your message, I just want to highlight here the importance of the prevention factor rather than entering into the high risk zone. Although, like what you have mentioned is that peak bone mass is at the age of 35.
Yes,
So,
around 30, 35. So depending on the ethnicity, and most will be around 30 to 35 years old.
yeah.
Yes.
Now, what I wanted to send the message that everybody should try to achieve that peak bone mass at the
I
35,
agree.
right?
Yes.
So not to think of at the 35 only, we'll start thinking of prevention. And
Mm.
that is where what Dr. Das was mentioning about healthy lifestyle and avoiding substance abuse. All these things can even before 35 itself, the peak bone mass can reduce. Thank you.
Exactly. Strongly agree. Absolutely. So, if you, any of you in this room, uh, it's not like at the age of peak bone mass yet. You still have some time to accelerate the bone strength, your bone strength, to achieve, the very high peak bone mass. And when it comes to the decline, you have more, more reserve than other people.
So that was a very illuminating lecture, sir. We enjoyed it very much. Since I'm a biochemist, actually, I have got certain personal agenda I want to place before you. Are there any studies in Thailand based on liver 25 hydroxylase and kidney 1 alpha hydroxylase to make sure actually that the endogenously synthesized cholecalciferol gets converted to calcitriol? Are there any studies there? Because liver and kidney health are also equally important if we need to endogenously synthesize vitamin D. Do you think in such of those people who have got a compromised kidney and hepatic system, do you advocate vitamin D and calcium supplementation, or it is just prophylactic, sir? This is my question.
So your question again, please. You mean the patient with some kidney disease, right?
Yes, sir. Yes, sir.
Yes, like the chronic kidney disease. Exactly. I agree with you. The chronic kidney disease will have higher risk of the metabolism of vitamin D, and also the osteopenia and osteoporosis. So it is essential, for, these patients to measure, to have the measurement of the vitamin Ds, and also to have adequate calcium and vitamin D supplement.
Thank you so much.
Any other queries?
I want to ask you that the high prevalence of vegetarian taking people, as you know, that paper by Amrish Mittal, all that you wrote, is about the high vegetarian population and vegan population now. Any message you have for them? I'm
You
taking
mean the vegan, right?
yeah, vegans.
So if you are vegan, but I'm not quite sure in India you drink milk, or even vegan you drink milk or not.
Some don't, but usually vegetarian.
So if you are vegan and you drink milk and you eat cheese, I don't think that won't be a problem. For the calcium deficiency or the bone loss. But for the purely, vegan, not drinking milk and not eating cheese, I think, we have found in some other studies very high prevalence of nutritional deficiency, like vitamin B and also calcium and bone health as well. So I think, for the vegan who do not eat cheese and milk, maybe a supplement of the calcium and vitamin D is important, or you may consider eating, some vegetable rich in calcium and vitamin D.
Thank you.
Thank you all for the engaging discussion. Gratitude turns a gathering into a memorable event. To deliver the vote of thanks, I invite Dr. Vandana S., Professor, Head, Department of Oral Medicine Radiology, IGIDS, and member in SBV Women Cell. Please.
A very good afternoon to one and all. Gratitude is the greatest expression of appreciation. It's indeed a great honor and pleasure for me, Professor Vandana, to deliver the vote of thanks on this occasion. First and foremost, I would like to thank our Chancellor, Professor Shri M.K. Rajagopalan sir, for his inspiring vision and constant encouragement and supporting such initiatives. Our special words of appreciation are due to our registrar, Professor A.R. Srinivasan sir, for his gracious presence today and for his soul-rendering Swagata Ragamalikam, which has culturally enriching tone for this program. We are profoundly grateful to our speaker for today, Professor Unnop Jaisamrarn, for his insightful and thought-provoking lecture. Sir, your valuable insights have greatly enriched our understanding of this important aspect of women's health. Our heartfelt gratitude goes to the Director Administration, Mrs. Asha Suresh Babu, for organizing such a significant lecture for today. We also extend our sincere thanks to all the heads of the constituent colleges, directors of centers of SBV for their encouragement and distinguished presence. A special mention should be made for the MC of today, Professor Rajesh Frimbi from KGNC, and for the chairperson of Women Cell and all the members of Women Cell SBV. We also acknowledge with gratitude all the on-stage and off-stage contributors such as the AV team, the IT team, the hall in charge, Mr. Kalidas, the other hall in charge people here, the administrative teams who assisted with permissions and communications for this event. Finally, I extend my sincere thanks to all the participants who have come here for celebrate this knowledge and women's health. Once again, I thank you all for your presence and support. Thank you and have a good day.
This brings us to the end of today's celebration. On behalf of SBV Women Cell and Department of Obstetric Gynecology, I extend my sincere thanks to our dignitaries, speaker, faculty members, and participants for making this event meaningful and memorable. Let us continue to empower, inspire, and lead in our professional and personal journeys. As we conclude this program, may I request everyone to rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you once again and wish you all a very happy International Women's Day. Thank you all.